So thank you again for attending, and I'd now like to introduce Associate Professor Patrick Bolton. He will provide the acknowledgement to country and also welcome us all tonight.
Fantastic. Thanks, Ellie. So welcome, everybody. As Ellie said, well, Ellie's given me my introduction, so I'll go on to the acknowledgement of country. I would like to acknowledge the traditional custodians and sovereign people of the Aboriginal land on which we are meeting today. I am on Gadigal land, and the Gadigal people are the traditional custodians of the land from which I'm joining. I recognise their continuing connection to land, water, community, and pay respects to elders past, present, and emerging. I extend that respect to Aboriginal colleagues joining us today. So why this workshop? This is a subject that is a bit close to my heart. One of my roles is to provide physical health for people with significant mental illness. And one of my learnings from doing that is that psychiatrists are not very good at anything but psychiatry. And since people with significant mental illness die at least 20 years younger than other Australians, that's a particular gap in the care of this group. And so it's really important for people with significant mental illness to have a GP.
Hi, sorry, Patrick, it looks like you're muted.
When did that happen? Did that happen long ago?
A few seconds ago. We just missed the last 10 or so seconds.
Okay, thank you for that. I have no idea how that happened, and I apologise. So people who are on clozapine have particular health issues. Clozapine is well regarded by psychiatrists. I've seen it work where other antipsychotic medications don't, but it's a really dirty drug. And we'll find out more about that as the evening progresses. And by dirty, I mean it has lots and lots of side effects. Some are very serious and the mental health service is obliged to monitor them, but others are less immediate, but ultimately no less serious and impact on the client's quality of life. And so it's for that reason, it's really important that there's somebody riding shotgun with the patient and with their mental health team to look after their physical health. Can we move on to the learning objectives, please? So the learning objectives for this evening are for clozapine to describe why and for what group of patients it is prescribed by mental health services, the benefits and side effects monitoring required, the role of the GP. I've given all this away. We can stop now. Describe the consumer perspective on medication management, reflect on shared care and care plans for patients with severe mental illness and how these could be improved, and consider the recovery, support and case management available to people with severe mental illness. That's the conclusion of my part. Do you want me to say here's Sarah, or will somebody else do it? Okay, so
I'm happy to introduce Sarah, if you like. Dr. Sara Buten, who's a staff specialist and psychiatrist at the Euroa Clinic at Prince of Wales Hospital.
Hi, there we go. Thanks. Hi. So, thanks, Mark, for the introduction. I'm Sara. So I'm going to go into a little bit of detail in the next while, talking about clozapine, you know, some idea of why we use it, schizophrenia in general. Before we go, I'd like to, and I'm not sure who's going to put this on the screen, we're just going to do a little bit of a poll. initially before I launch into just asking you about some questions around schizophrenia. So if you guys can all, mark what you think it is. Okay, great. Okay, so everyone's answered. That's great. So I can see most people did agree that it can include all of the above. So disturbance of mood most probably is the least, but it can include that. Definitely a disturbance of thoughts, bizarre ideation or delusions, and a disturbance and perceptual disturbances potentially as well. Sorry. Okay, so that was the results. Now I'll stop sharing and we can carry on. Okay, I don't know if we can, well, I'll carry on. Maybe we can close it. Thank you. Okay. So, what I'm going to talk about today is clozapine and the approach in the prevention and maintenance and treatment of schizophrenia. So schizophrenia is an illness, as we said before. It can comprise of the positive symptoms, which can be delusions and perceptual disturbances, but also negative symptoms, which would affect functioning and include things like amotivation, avolition, the difficulty in doing things. It's a complicated condition. And I guess from my point of view, and I think, what you heard from Patrick as well, it definitely demands a holistic approach, looking at not only the medication and the biological aspect, but also a lot of the psychosocial, the psychosocial. So biological management includes typically the use of antipsychotics, one of which is clozapine. But before clozapine, I guess it's really important to look at other medications. And I think I have gone ahead, so we won't do the poll. And so with your antipsychotics, you've got what we would refer to as our typical antipsychotics, the older ones such as haloperidol or zolpidem, clopixel, and then newer agents, which most of you would be more familiar with, I would think, such as risperidone, paliperidone, olanzapine, Zyprexa, quetiapine, Seroquel, and aripiprazole, Abilify. So I guess with clozapine, when would we think to use clozapine? So it's typically not our first line treatment. We reserve it for what we call treatment refractory or treatment resistant schizophrenia. And I guess by that, what I'm talking about is a schizophrenia where there's lack of response to at least a trial of 2 other antipsychotics. So using a proper dose of it for at least 4 to 6 weeks, an adequate dose and adequate time frame. And then we would go to clozapine, and clozapine improves a whole lot of things. As I said before, it's both the positive and the negative. It can improve memory, mood, thinking, behavior, by balancing the different neurotransmitters in the brain. And it is our best option. It is an amazing medication, but as I'll go into a bit later, there's lots of potential side effects as well, and it's finding that right balance between it. So clozapine is also used in illnesses, so not only for the treatment resistant, but also used where there's other maybe side effects. So other medications have not been tolerated, for instance, where there's extrapyramidal side effects or things like tardive dyskinesia. And then we might go to clozapine sooner rather than later, sometimes in older people, so there are all sorts of considerations that need to be taken into effect. So the benefits of clozapine definitely, it, as I said, not only that it targets all the symptoms of schizophrenia and probably our best treatment available for that, but also it can help with suicide. It can, as I said, with tardive dyskinesia, reduce that, or there's lower risk anyway. It can improve cognition because and that's probably because you are treating the illness so much more effectively. There can be decreased relapse, and even with substance use, it is linked with diminished use as well, which is really, really good. And actually, like even in our younger population, we might consider going to it earlier than before, for that whole idea that we want to really optimize treatment and get these symptoms controlled as soon as possible, functioning back to optimal status as soon as possible as well. So then going on to, I guess, sorry, I've gone to, the next thing, that there are some contraindications to the use of clozapine, and these slides as well will be made available to everyone. So I don't want to overload you, but just things like a history of, white cells or granulocytosis, granulocytopenia, bone marrow dysplasias, circulatory issues, if there's CNS conditions, hypersensitivity. If it's for, we wouldn't turn to it if the psychosis is due to alcohol or other substances. And also if there's physical compromise, renal, cardiac, hepatic disease, uncontrolled epilepsy, paralytic ileus. And this will go towards something that I will talk about a little bit later, with the side effects of the clozapine. So with clozapine, it's manufactured by two companies, Clozaril and Clopine. We use Clopine, and both Clopine and Clozaril have patient monitoring systems, mainly due to the agranulocytosis. And so every doctor that treats anyone on clozapine has to be registered, and every hospital or medical center also has to be registered with Clopine in this case before they can prescribe clozapine. And the same goes for every client, every patient who's on clozapine. Before treatment, they also have to be registered, and that will include regular monitoring. And I will go into it a little bit more, but actually one of the tests we do before they started is a blood group. And the reason is not because we need to know the blood group, but it all goes towards the identification and just making sure they are registered using that. Just to note as well, if a person moves area or is transferred from another clinic, we have to link them in to that specific Clopine. Clopine Central must be aware so that they're linked into the appropriate center. So this is just a screen to show you, how everyone has that profile on Clopine. They have a Clopine patient number, CPN. We get any provider will get a login and a password from Clopine Center, and so you can see this. And all the blood results are then logged in there, the dose information, when they started on it, when they reached the 18-week days, and so the weekly, monthly. And it can be important because there's hematologists and everyone who are working with us and with Clopine. And if someone has different parameters but have been on it for a long time, sometimes the hematologist will change that with on Clopine. That, for instance, we don't need to worry about their white cells. I'm happy, we'll take questions at the end, and if I'm getting too complicated, don't worry about it. So with the dosing regime, it usually is very individualized to the patient. So it's not to say that, we'll aim for a certain dose. When we've got a titration plan, and I guess someone like the GPs or whoever are involved, hopefully the client will be really well maintained on it on a regular dose. But I just thought it's good for everyone to be aware. It is quite a complicated process to get there. So we'll start on very low doses and gradually increase. Clozapine do recommend a twice daily dosing. In the beginning, yes, often that's done towards the most people, and I guess we'll hear later from, Joe potentially, but they do prefer a night-only dose, and that's because sedation can be a side effect. Most often, we can go slower with the titration, depending on side effects, and we can go quicker if needed as well in certain cases. Response is usually seen at a dose 150 to 450, but everyone's very different. Maximum dose, we say 900. I have seen people, like for instance, from the forensic system that are on way higher doses. So it's all very variable. Then once again, in elderly, females, non-smokers, or if they're on certain medication that might interfere with the metabolism, lower doses. Plasma levels useful. It's not as exact as certain medications like lithium. We've got much more tight parameters that we know. For me, the levels are really useful. Number one, for toxicity, which is something I'll get into a bit later, but we do want to watch that we don't go above, and definitely above 1,000, increase the risk of seizures, that kind of thing. The other thing is with compliance, it can be really useful as well. And to know what a useful dose is. If someone's symptoms are controlled and say a dose of 200 milligrams and then their level is 250, then we know for them that's a great level, and so we can do that. Levels are processed at, I think it's RPA here in Sydney, and it does take a few days. So it's not instant. We don't get the results back like you would for an FBC on the same day. So this is the titration, and not to worry about it, but just to see that, you have to go really, really slowly, and that's what does take some time to get someone onto Clozapine. Okay, so before I go to this, it's time for our next question, and it's actually, I missed the middle one, so it'll be the third one. Just wanting to ask people to do a bit of a poll around concerns with Clozapine, and if you all could have a go at what you think potential side effects would be, any alarm bells. Okay. Time. I think everyone's answered. Thank you. Share the results. So, yeah, I'll go into it in a little bit more detail, but cardiac issues, well, one put that as, I guess, that would be the only problem. Immunological, mainly with the white cells. Metabolic issues, weight gain, lethargy and fatigue. And then 16 out of 23 put all of the above. And yes, all of the above is the correct answer. And we will go into it now in a little bit more detail. But yes, Clozapine is, as I said in the beginning, in my opinion, it's one of the most fantastic treatments we have. But yes, it does come with a lot of side effects. But then again, I guess a lot of the medications that we use for the treatment of this illness do come with a huge amount of side effects. Okay, so I'll stop sharing and then carry on. Okay, so as we said before, hematological or the monitoring of the white blood cells is definitely a cornerstone of Clozapine. When Clozapine was first came into use, and that was in the 50s, initially there was a death, and it was related to agranulocytosis. And very soon thereafter, it became a medication that very strict hematological monitoring has been enforced. Well, I definitely know in Australia, I think in other countries, it might be a bit different. I mean, just offhand, I had one client who spends a lot of time overseas, and she, you know, she had a psychiatrist prescribing it with no blood tests. And once she came back here, very much had to reiterate, no, here in Australia, we have to have the monthly blood tests. So it's a very rare incident, the neutropenia. And I'm glad to say that now that it is monitored, we haven't, you know, the adverse effects are, you know, it doesn't happen. If anything, you know, the use is maybe stopped, but also very, very rarely. So when anyone started on Clozapine, we have to do that baseline full blood count, the white blood cells and the neutrophils. And then for the first 18 weeks during that initial period, it's on weekly blood tests. To get the blood test, and I'll talk about this, and you're probably all familiar, we can write the hematology forms using the Rule 3 exemption, which allows 6 repeats. So you would need that weekly, initially lasting 6 weeks when they're having weekly bloods. But once they go into monthly, just one form can last 6 months, which is great. Clozapine cannot be prescribed without a current full blood count result. And we need to very, very stringently monitor for any signs of infection. So the white cells are good, that they'll give us some sort of an indication. COVID for us did, I mean, you guys would have had it very much in your face, but with Clozapine and the risks, it's something to just very much be aware of. And even now, at the first sign of any infection, just to test for it, make sure it can affect levels as well. So just good to be aware of it. If someone does have an issue with their white cells, on rechallenging, it can be an ongoing issue. It's not necessarily a dose relationship. So high doses doesn't necessarily mean white cells will be affected. And there is a hematologist that we are working within our Clozapine clinic are very, you know, familiar with. But that's one of the great things that we do have access to, which is very, very helpful. So with hematological monitoring, we want clients to be in the green zone. And this is something I've got on my, you know, I keep on me in person. You do learn it, but it's good to have. And as long as the white cells are above 3.5, neutrophils above 2, they're in the green zone. Great, you continue with weekly or monthly monitoring. If they drop either to the amber or the red, so if they drop to the amber zone, they then need to, we continue the Clozapine, but we'd only give a week supply. And they would need the FBC repeated 2 times a week until they go back to the green zone. And if someone goes into the red zone, the advice is you stop the Clozapine and then we consult the hematologist. So I always will get the person straight away to go into ED, make sure they're okay, make sure nothing else is going on, and then we consult with Clozapine. And most times we can continue. I mean, I haven't had to stop, which is great. Okay, so that's the hematological. The next thing is cardiac, which most of you did put was a concern. So with Clozapine, the 2 main issues with the heart are myocarditis and cardiomyopathy. Now, myocarditis, there have been some fatal cases and there has been cardiomyopathy reported. It's rare. The incidence is slightly higher in Australia. Not sure, once again, if that's because we do monitor and check on everything. And myocarditis most commonly occurs early on, so it's 6 to 8 weeks of starting, especially around week 3 of treatment. Cardiomyopathy later, generally within 9 months. And as Joe will go into a bit later, all the clients who we are keen on, you know, doing the shared care, will have been on clozapine for at least a year. So hopefully that's not too much of a concern, but just to be aware of. And I guess the myocarditis can be, you know, very vague, non-specific symptoms, tachycardia, hypotension, unexplained fever, flu-like symptoms, fatigue, shortness of breath and tachypnea, chest pain, ST depression on ECG, and then non-cardiac, like diarrhea, vomiting, dysuria. So it's just important to monitor for these non-specific symptoms of illness, such as the fever, or as I said, the non-specific, and then the CRP and the troponin typically do increase. Sudden drop in blood pressure may occur around this time. The non-specific ECG changes also can occur, basal crepitations, and echo as well is important to get because that can show impairment of the left ventricular function. Heart rate typically increases, but often with clozapine, heart rate increases. And yeah, in some cases, the myocarditis can even develop without accompanying symptoms. So just something to be really, really aware of. I know at Prince of Wales, we've got a specific myocarditis protocol. Yeah, so there's lots of support around that as well. Okay, so just as far as the monitoring goes, initially when someone starts clozapine, they will have a baseline echo, ECG, troponin, and CRP. Then the troponin and CRP we do weekly for the first 4 weeks, then again at 6 weeks, 18 weeks, and then 6 monthly unless indicated. The ECG also initially at 4 weeks, 6 months, and then 6 monthly unless indicated. Echo we generally do initially and then after 12 months, and then only every 5 years or so, unless there's other indications, and often will involve cardiologists if you know there are any cardiac indications. Just to note, there can be lots of drug interactions, and the psychotropic medications are notorious for the raised QTc in general, so just something to be aware of. Okay, then as with a lot of our medications and unfortunately metabolic issues, weight gain, issues with sugar, issues with cholesterol are all ongoing concerns, and that's why it's really, really important to check. So baseline, make sure metabolic syndrome, and then just look at the risks and manage it. So we'll always do the fasting glucose and lipids initially. And there is a metabolic monitoring form that we use, but just to include weight, height, BMI, waist circumference ongoing, and just to keep track of that. And as Patrick said in the beginning, that's why it's so great having, you know, the GPs so intrinsically involved to ensure that, you know, this is kept track of, because as he said as well, us as psychiatrists, we're good at, you know, or we tend to emphasize more, you know, the psychiatric or the mental health side of things, but the physical health is impacted and very, very important. And, you know, as far as the impact on life expectancy, it's a huge problem. So then we'll do fasting glucose and HbA1c as well, baseline, and then 6 monthly. Diabetic obviously is different, and you'll do it more regularly. And then lipids also 3 monthly initially for the first year, and then every 6 months. Very good to commence the metformin of statin, vibrate therapy if indicated. And once again, that's why it's great having you guys so intrinsically involved, and just to encourage smoking cessation. And I will go into its impact on levels as well. And then with the cardiac, we also doing the troponin and the CRP monitoring. So on top of that, it's also important to look at the EUC, the renal and electrolyte, the LFTs, vitamin D, thyroid function, I add on every 6 months, clozapine levels as well. And if they're on any other medications where you can monitor levels such as lithium or valproate, it's good to do it as well. Okay, so just to recap, and once again, it's very complicated, but that's what's good to have in front of you. For blood counts, that's an ongoing thing. Anyone on clozapine, as we will attest to, no matter how long or how short you've been on it, first 18 weeks, every week, and after 18 weeks, it's every month, every 4 weeks. Clozapine treatment should not be continued without an up-to-date full blood counts, which needs to be reviewed by a doctor each month, and then clozapine to be supplied. And Joe will go into that as well. When we do the scripts or whatever, we actually have to send to the pharmacy a copy of that full blood count as well. Troponin and CRP, initially more often, week 1, 2, 3, 4, week 6, weeks 18, and then every 6 months. And then, and that's to do with the myocarditis, and then the levels. And as I said, because it's not done through all the labs, it takes a while to get through. If the person as well is on a twice daily dose, just remember to withhold the morning dose, or advise them not to take the morning dose so we get a trough level. Okay, and then the glucose and HbA1c and the lipids, other things, at least every 6 months for anyone on clozapine. Okay, and so now I'll spend a little bit of time talking about the adverse effects and potential management. Am I going for time? Okay, perfect. So sedation is an issue with clozapine. Typically, there is some sort of desensitization, or as you get, it does wear off. And that's why as well, we go so slowly with the titration dose. Most people do prefer the larger dose, therefore, at night. And if needs be, you can decrease the dose or go up slower, depending on the sedation as a side effect. Hypotension, postural hypertension, so that dizziness when standing up especially, can be an issue. Also generally something that does sort of settle. So the first 4 weeks especially, we give advice around that, making sure fluids are kept up, taking time when standing up, not to go straight from lying down to standing up. And if needed, once again, going down on the dose and going up more slowly. Hypertension might be an issue, which is something we need to monitor closely and treat as needed as well. And the side effects go on. So tachycardia is something that's actually quite common, often more in the first 4 weeks, but it can be quite common, and we'll often see people whose baseline heart rate is above 100. There is, as I said, the New South Wales guidelines for myocarditis and the monitoring protocol. And that's very important because any acute changes, just to make sure that there isn't, the potentially life-threatening myocarditis. Fever is another non-specific thing that may develop and may also confuse with that whole myocarditis picture. So just to be aware of and on top of and keep track of. Nausea, typically in the first 6 weeks, might need an antiemetic. Hypersalivation is an issue that may persist. There can be some tolerance that develops, hopefully wears off. We offer, and through clozapine, you actually can get the absorbent pillowcases. We used to use atropine, but that has had some cardiac issues, and so we no longer recommend that. Quells can be used, can be quite costly. An off-label thing that I've started trying and suggesting is buscopan hyoscine, just to take half a tablet at night. May or may not help. There's some of the patches as well, which can be more costly, but we have prescribed that through our hospital pharmacy if needed as well. A big one, though, for you guys to be aware of, and something that we ask about as well, whether it's through the nurses seeing the clients, whether it's through us at all our reviews, is constipation. You know, there have been some potentially fatal, including intestinal obstruction, ischemia, perforation. So it's something to be aware of. Ensure that it is managed, that people, you know, are aware that yes, constipation, it is an issue with this medication, and people are on osmotic or stimulant laxatives ongoing. You know, Movicol is something that some people just take each day, twice a day, ongoing. The main thing is to keep on top of us and of it for the client and for us as their you know, as their doctors, to also keep track of and make sure that it's not an issue. Weight gain, so huge issue. A lot of antipsychotics do it. By implementing dietitian exercise, it can make a huge impact, and it can absolutely reduce that initial weight gain. And now more recently with our newer agents, I mean, metformin is something that we recommend, you know, to be used very, you know, very easily. And then now with our newer agents like Ozempic, hard to get, but if possible, where we can get it, and depending on costs, limitations, you know, great results can be seen, as I'm sure you guys are seeing. And lastly, nocturnal enuresis. Because of the sedation, waking up at night can be a problem. And so, you know, if needed, limit fluid intake, take the tablets a bit earlier. And there is the pharmacotherapy, where having a GP involved is really, really helpful for the client, helpful for us as psychiatrists, etc. So as you can see, a huge amount of side effects, but important to keep less frequent but serious side effects, just to be aware of. Seizures, more likely with rapid titrations and above a level of 1,000. Sometimes we do consider prophylactic anti-epileptic like valproate dose if the level is needed and a high dose is needed. Pulmonary embolism, thromboembolism, NMS, hypothermia, you know, just to monitor for, you know, any change in vitals, changes in cognition, muscle rigidity, or increased CK. And then sudden death has been noted, which is, you know, where a lot of the fear, I guess, around this medication does come, and understandably so. Just to note as well, very important to take the medication regularly. Kind of interruptions in therapy. If you miss a dose of more than 48 hours, or more than 2 doses, has to be retitrated. So just something to very much continually warn about. And lastly, just to note that certain medications might increase the levels, smoking, increase or decrease the levels, so important to ask about, and caffeine as well may affect it. So just to be aware of. We do use fluvoxamine actually to try, sometimes need lower doses. So with clozapine, especially after the first 18 weeks, it's important to provide the maintenance care, the physical health care, ongoing monitoring of side effects, metabolic, and help with the prescription, to provide preventative care, to ensure regular blood tests are done on time, and to refer back. So anyone at husband needs to be seen by a psychiatrist at least every 6 months, and more frequently as necessary. And as you'll hear, we need to report any adverse effects to Pfizer's drug safety straight away. The shared care arrangements, and I'm going to soon introduce you to Joe. That's something that we have started at Prince of Wales, Clozapine Clinic Mental Health Service. So once again, if anyone is in part of this program, if their blood tests change, if there's issues with compliance, if the dose needs to be changed, any side effects, please, or if the patient themselves is requesting it or their family is requesting it, don't hesitate to refer back to me or to the team in general. So now I'm going to next introduce you to Joe, who is our care coordinator, Clozapine coordinator for this GP shared care program. And then at the end, we can take some questions. Thanks, everyone. Hi there. So thanks, Sarah. I'm just going to run over briefly the GP shared care program, and just like taking some of the information from this extensive brochure that Pfizer put out for Clozapine. Yeah, so what so I'm the coordinator, so I facilitate the initial patient transfer from hospital care to GP care. So before I would introduce anyone to GPs, I go through an eligibility process of looking at our consumers, ensuring that they're stable on Clozapine. They would have definitely finished the first 18-week titration and been on Clozapine for at least 1 year. So like I said, stable. Always I'd have a look at their blood results that they have every 28 days and ensure that they're always regularly come back in the safe green zone that they're required. And patients that get their blood tests regularly on time know how to keep up the regime of 28-day blood tests, and collecting their medication from their chemist, have a good relationship with the GP and the pharmacist, and look at if they've had a recent hospital admission. Yeah, so once I've gone through all of that, I discuss that with our psychiatrist, and Sarah, she'll let me know if she feels that they're suitable to go out to the community and have their GP prescribe the Clozapine, and if she believes that they're stable and good for that, then I'll talk to the patient and ask them if they're interested, explain the process, and the carers or their family, or whoever else, whatever other supports that they have, I'll include them as well. And then if they agree and want to do that and have that independence, that they'll go and get their scripts from their GP, then we'll make an appointment to visit the GP together, go out and introduce ourselves and the GP, go through the whole process, and ask the GP if they are willing to do the prescribing. And if they are, then I'm like I'll register GP and the pharmacist with Clozapine Central, and provide the education on how to use the database, and link the GP then with the pharmacist and the pathology services. So the GP writes the pathology forms, and I would explain everything on how to write the scripts, the Clozapine scripts. And yeah, so it's just basically a process of ongoing support and education, or someone who's always there to answer questions. I'll visit the GPs with the patient and carers until they get the routine and everyone's comfortable with the process, and also to make sure blood tests have been entered into the Pfizer database, and
are always a contact here at Prince of Wales at the Clozapine Clinic to for support for GP if they feel there's any like concerns with the consumer and help with them coming back to us. They're never the consumers are never discharged from us. We're always there, and they can come back to the hospital system. And also I would be like also liaising with the any adverse events with Pfizer. Then the responsibilities of the GP would be to provide that every 28 days the consumer would come in for an appointment, and one of the biggest advantages is the physical health assessment. The GPs can have regular contact with these consumers that are on Clozapine to assess physical health, check in with if they're experiencing any side effects, and checking bloods for metabolic changes and writing the script. And GPs are never like expected to change doses. It's just basically for stable patients to stay on the same prescription every 4 weeks. And also GPs then would be like readily available to provide preventative care, health, like physical health care. You also have to ensure that the blood tests are done. So you'll be checking the blood test that goes together with the script and must be like seen and checked that they're in the green zone before you print out the script for the patient. And that's the white cells and the neutrophils that you're looking at as every 4 weeks. And then it obviously referring back to the treating psychiatrist at Prince of Wales if there's any concerns, and also reporting adverse events to Pfizer, the Clozapine central database. And then the psychiatrist, as Sarah mentioned, they have they're never discharged. They still have an ongoing responsibility with the whole shared care team, and they obviously initiate the treatment in the beginning, and then they continue. Well, these patients that are on the GP shared care for prescribing, they would have finished their initial 18 weeks titration, and the psychiatrist would always be the one that would adjust any doses and would have a regular review every 24 weeks with the patient, and the psychiatrist would also report any adverse events to Pfizer. So that's about the process for us, for the shared care thing.
Okay.
Any questions?
So there's one question from Rula Ali in the chat of Sarah, and that was, why check the vitamin D and the thyroid function tests at 6 months? Does it affect the level as well?
So the reason that I've included it is just so that you are, I mean, there's no specific concern around vitamin D specifically or the abnormal thyroid functions, but it's just such a good way of keeping on top of it. I mean, definitely since I've added in the vitamin D, we have noted just how prevalent the vitamin D deficiency is and such an easy rectifiable thing to assist with. So it's just been a good way of being more holistic. Thyroid as well. It's something, we are using as a way of keeping track of it and then implementing change. I think we do have an endocrinologist who works with us as part of our Clozapine clinic and who works with Patrick and who can see, some of the clients. And I know he as well likes to just keep track of it. And so I guess it's just been added into part of it. The levels are just once again very important for others. So LFT is important to keep track of because that can be affected. The kidney are used also as another tracking tool to have on every 6 months. And then the other drug levels are if they're on other medication, just that we keep track of it and we are being as rigid and as diligent as we should be. I hope that answers the question.
Are there any other questions? If anyone would like to unmute and they can ask questions, or Rula said thank you, or you can type them in the chat now. My name is Mark Harris, for those of you who haven't realised. I'm from the Centre for Primary Healthcare and Equity at the University of New South Wales. The case study is on your screens at the moment. I'll just briefly read it out and then talk about some questions that we'd like you to reflect on in the small groups. You'll be in the small groups for about 15 minutes. We're splitting you into 3 groups, and I'll be facilitating one. Patrick Buten, who you met at the beginning, will be facilitating another group, and Sarah will be facilitating a 3rd group. So we'll spend about 15 minutes in the groups discussing the cases, and then we'll come back together for a bit of a wrap up, but also some next steps. So make sure you don't run away after the small group session. We do have a few things to talk to you about just at the end quickly. So the case study is a 24-year-old man with aggressive and violent behaviour who's referred to the mental health service. He was expressing delusions of being watched and appeared to be talking to himself, quite agitated, and had poor sleep. Prior to this, he's been a university student but had dropped out, and he was working as a labourer in construction and living with his mother and father. He had no other medical problems. And he was initially treated with risperidone, but this was discontinued after he developed a tremor. He was then prescribed olanzapine, but his paranoia and feelings of aggression were not controlled, and he expressed suicidal ideation. Finally, he was commenced on Clozapine, increasing over about 18 weeks to 150 milligrams twice a day. Over this period, his symptoms improved, and on week 19, he was discharged from hospital outpatients to shared care by his GP. So if I can have the next slide. So on the side, you've got the same case that we talked about, and these are the 4 questions that we'll be discussing in the discussion groups. So reflecting on why Clozapine was prescribed for this patient. Secondly, what monitoring is required for a patient on Clozapine, particularly from 18 weeks. What history, examination, blood tests, and investigations are required to do this monitoring. Thirdly, what goals need to be considered for a care plan for this patient? And finally, when should the patient be referred back to the mental health team or elsewhere? So we're about to break into the small groups, and we'll be discussing this case and these questions in the small groups. Reminder that you'll be given, each of the groups will be given a minute or 2 warning, and then you'll be brought back in after about 15 minutes. So I just wanted to say a few things at the end to thank everyone, first of all, for all of you for participating, and our presenters, Patrick Buten, Sara Buten and Joanne, and also Joey for presenting. I think that was fantastic, and I hope the other small groups, certainly the small group that I was in, had a great time addressing the case study questions. We're going to be just a reminder that after this, we'll be sending out a post-activity case study for you to complete, for the GP participants to complete as part of your CPD activity. And you'll also be getting an evaluation questionnaire to complete. In that, we'll ask you whether you're interested in shared care. You're not committing to it, but if you are interested in participating in shared care of patients with severe mental illness, we can put you in touch with the mental health services and talk about some of the options that might be available for your patients.